Thank you, Anna. So welcome to the sixth annual interdisciplinary talk data competition, the final round. So congratulations all of you for being here. I remember the very first time this competition, it was going to be in person, and then COVID hit. So it was, juggling it with in the middle of this 2020, trying to move everything to Zoom. So I'm really happy that we're back in these days where we can actually see. My name is Pınar Karacamandic. I am the founding director of BAC, also a faculty member here at the finance department at the Carlson School of Management. And why healthcare is my thing, I'm a healthcare economist. So that's why I am so thrilled that you're all here interested in data, and we have opportunities like this where we can help all of us learn more about interesting data sets. So today's schedule, we are just a couple minutes early, and then we are going to start with team 7, then team 10, team 1, and team 14. And basically, I just want to emphasize that this has no order. The order does not have any meaning on scoring or anything like that. It's just randomly selected. And I would like to thank our first round judges and final round judges as well. They've done a lot of work, which you will get to know now. But before that, I just want to put in a quick plug for our Convene conference. And this is BAC's upcoming conference on April 9. And we think, if you look at the topic, we think that all of you will like the topic, responsible AI, high impact and low risk healthcare. And we work really hard to put an amazing program. So if you haven't done so, please take a look at our conference website. We really have an amazing lineup of speakers and enough networking time for you to get to know some of the speakers and everyone else in the audience as well. Now, overview of the data competition. As I said, it started in 2020, and from the very beginning, the core theme about this was interdisciplinary. And why interdisciplinary, as you would appreciate, and as I am also, like, from an academic point of view, always a big fan that healthcare does not stand on its own, does not belong to a single discipline, does not belong to a single sector. And I also emphasize a lot that healthcare is so complex because all of those disciplines and sectors intersect with each other. And really, when we can start dialogue across the disciplines, where we can really understand the problems and put attention on them. Otherwise, they go overlooked and not understood. So this is why we started doing this with a collaboration with multiple schools and colleges at the University of Minnesota. And we've added other schools like over time as well. So now we're really excited. In addition to Carlson School, we have Institute for Health Informatics, College of Pharmacy, School of Nursing, School of Public Health, School of Dentistry, Medical School. And if we're missing schools that we know people that are interested in this kind of a competition, please let us know and connect us so we can add them to our steering committee and our programs going forward. So just a snapshot of this year, we had 62 students participating on 18 teams. And again, it's interdisciplinary, as you know, so each team has to have at least 2 of the colleges represented. So we had 13 of the University of Minnesota colleges and schools represented in the competition. And again, it gives me really great joy that we can do this, as you can see here. And University of Minnesota is so unique as a land-grant institution to have these. I think we have 14 colleges or schools, so we have to find the 14th missing on Becky next time. Extra marketing on fill in your notes to get the 14th college and school represented as well. And our judges also come from different disciplines at the University of Minnesota, but also industry experts from all sorts of organizations. So our goal, as I always emphasize, is to promote this interdisciplinary dialogue on how to use data to address current healthcare challenges, and for the students to showcase your talent and understanding of the data. And as a lot of you know, healthcare data can be very complex and ugly and dirty. So our goal also with the competition is to give you as clean of a data as we can, And of course, we can't always deliver it, like data can never be super clean, but we don't want you to spend your time, cleaning the data, but rather once you're given clean data, what can you do with it? And what kind of questions can you ask? What kind of insights, what kind of solutions you can come up with? So again, this year's theme, we said it's healthcare provider deep dive, connecting quality payment and social context. So as you can see, it was what you worked with was a healthcare provider level data set, where we also supplemented the data set with quality and payment information and utilization, as well as the social context of where the healthcare providers are practicing. And as usual, again, every year, we leave the challenge pretty exploratory in that we don't give you a very prescribed question for you to solve, but we say, here is a data set. Here's an interesting data set that we think is interesting. What can you learn from it? What kind of relationships can you look at? But also we want to take it one more step forward and say, it's great that you see a trend, but what does that mean? What is its policy impact or a delivery impact or a business impact? And what is that telling you about some of the challenges and opportunities? And what are the implications? What can you do with it? And again, every year we get student teams creating either sometimes a policy innovation, an interesting design, sometimes a business innovation. It's just really exciting to see. So again, our required data set was one required data set, and we were thrilled to be working with Yubin Park, who's one of your judges, final round judges, and Mimi Labs. And we basically said, let's put together these different kinds of components of the data that are in the public domain, but let's kind of put it together and see where it goes. So we had the provider data, we had the quality payment program data, we had the Medicare utilization and payment data, and also the CDC places data that were all kind of merged together at the provider level. So I'm really excited to see what these 4 teams will present, but all judges complimented, honestly, like the quality of the work across the board. So I want to thank all participants. And our first round volunteer judges, as you can see here, again, representing different industries or organizations. We have University of Minnesota faculty, again, from different schools, reviewing our projects. And then our final round judges, I'm going to go, and then maybe if you can raise your hand very quickly and say like 1 sentence or 2 sentences. Haley Bork, Managing Director of Data Science Initiative.
Hi, I'm Managing Director of Data Science Initiative, and I have a background in computer science and AI, so I'll be looking for that kind of stuff there.
Heather Britt, Executive Director of the Wilder Research.
Hi, everybody. Heather Britt, epidemiologist by training, spent a couple decades in healthcare, and now lead a community-based research organization in the Twin Cities. So super excited to be here.
Benjamin Lynch, Director of the Minnesota Supercomputing Institute.
Hi, I'm Ben Lynch, Director of MSI. We provide computing resources to about 1,000 research groups across the University of Minnesota and other institutes for higher education in the state.
Thank you. And Yubin Park, CEO and founder of Mimi Labs and our data partner.
Hi, guys.
All the names go to you.
Yeah. Good to see you guys in person. So.
Yes, because you guys have been communicating.
Yeah.
So, all right, and then we have awards for the top 3 teams. So awesome. And I want to thank our sponsors, our distinction sponsor, Research Computing at University of Minnesota, our maroon sponsor, the color maroon, Data Science Initiative, and then our community sponsor, Office of Academic Clinical Affairs, OACA. Okay, so that's basically random selection of the team. Each team will have 20 minutes to present, followed by a 5-minute Q&A with the judges. Because of the time constraints, we're not going to take questions from the audience here or online. Now, a quick reminder, if you're the student presenting, Please be sure you have a microphone, right, so that our virtual audience can hear you, although this room's mic system is pretty good. Yes, team 7, you're up first.
Put these on.
That too, yeah.
You know if it's on.
Yep, I just got a check from the group here. Everyone's good.
Okay.
Yep.
So. All right, good afternoon, everyone. I'm Jake.
Hi, and I'm Ethan.
And we are excited to share with you our work, Bridging the Digital Divide, Pathway for Small Practices in Promoting Interoperability. So in approaching this year's competition theme of connecting quality payment and social context, we sought to first understand the objectives of the quality payment program. Of the 10 reported objectives, these 3 in particular stood out to us in driving our analysis and policy recommendation. To improve the care received by Medicare beneficiaries, to maximize QPP participation through education, outreach, and support, tailored to the needs of practices, especially those that are small, rural, and in underserved areas, and to continuously improve QPP based on participant feedback and collaboration. At the core of the QPP is the merit-based incentive payment system, where providers are scored on a variety of category measures determining whether their billed Medicare amount receives a positive, neutral, or negative payment adjustment at the end of the year. The standard MIPS score is calculated as such across these 4 categories. 30% weight given to quality category score, 25% to promoting interoperability score, 30% given to cost category score, and 15% given to improvement activity score. The data used for our analysis comes from a variety of public health data sources. The first 2, gathered and provided by Mimi Labs, are coming from the Center for Medicare and Medicaid Services, which has individual provider data on identifiers, gender, specialty of the practice, state and zip code information, QPP level data, the practice's participation status, rural status, practice size, their MIPS final score, and their component scores, along with their associated category scores. Also, Medicare utilization data on the services provided, the charges and billing, and the demographics and conditions of the beneficiaries served in their area. We also get data in the CDC places from the Center for Disease Control, which has percent of population with given health conditions both by age and zip code. To this, we add data from the US Department of Health and Human Services about Medicare beneficiaries by zip code, and data from the Census Bureau about 65 and older population by zip code.
So with these data, we chose to investigate the topic of practice size, specifically regarding small practices. The importance of the interplay between practice size and quality care cannot be overstated. Small practices have unique strengths and challenges in delivering quality care. Previous studies have reported lower average MIPS scores among providers at small practices. In this project, we aim to uncover patterns that could inform the support of small practices in delivering high-quality care.
So what we see here is the difference in final MIPS score between small and large practices, where more red indicates small practices having lower scores on average, while green indicates small practices having higher scores on average. What we see here is an overall trend of small practices underperforming relative to large practices in their final MIPS score. Looking now at the 4 individual components of the final MIPS score, we can see the driver of that difference in final MIPS score is predominantly coming from the promoting interoperability category. Again, interpreted here as red, meaning small practices scoring worse in that category relative to the larger practices. This promoting interoperability category focuses on metrics relating to the practice's electronic health record technology implementation and usage in the practice. Now, there are a number of existing resources in the QPP for small practices to maintain fairness with the larger practices in regards to their final MIPS score. So the first is in their quality category score. 6 bonus points are awarded in the quality category score to small practices for submitting at least one category measure. 3 points are also awarded rather than 0 for measures that don't meet data completeness criteria but are nevertheless reported. In the promoting interoperability category, small practices can take an exemption. They can automatically have their PI category score weighted at 0%, down from 25%, and that percent reallocated to the quality category score, which will now be weighted at 55% rather than 30%. Although small practices have their PI category score weighted at 0 by default, they can still choose to opt into the PI category and report their scores. We see that 69% of small practices exercised the 0% PI score weighting option in 2022. All practices also have access to the Quality Improvement Organization, or QIO programs, which are federally funded organizations via the Center for Medicare and Medicaid Services to provide targeted support for Medicare serving practices, including helping physician practices use electronic health records to their full potential. However, despite these resources, small practices received 0.7% less in payment adjustments than large practices at the end of the year. And they also held 12.5% higher quality scores on average than large practices. Our analysis looks to unpack this difference in quality category scores, as well as understanding the differences in promoting interoperability scores. In exploring the drivers of the large differences in PI scores between small and large practices, we constructed some measures to capture some hypothesized drivers alongside their small practice status. So factors that we thought may be impacting low PI scores for small practices could be the time available to them to implement electronic health record systems, which we measure with an understaffed measure, which we calculate as high patient to practice size ratio, an overworked measure, which we calculate as a high services offered to practice size ratio. And then we also hypothesize that provider patient technology use being a PI category score component, if there's a high proportion of Medicare beneficiaries relative to local demographics, that could be an obstacle due to that community's availability to technology. So using a series of linear regression models, we are looking to understand 2 things. First, is the high quality category score that we observe in small practices solely a product of the 6 bonus points allotted to them by the QPP setup? And second, do those hypothesized drivers of low PI score also negatively impact quality category score for these practices? After controlling for our hypothesized drivers of low PI scores, the other 3 category scores, beneficiary demographics, state-specific effects, and primary specialty-specific effects, we see that across the first row in this table, our estimated coefficient for small practice ranges between approximately 13 and 16, meaning that even accounting for that 6-point bonus allotted to small practices via the QPP, the quality category score for small practices is still 7 to 10 points higher in the quality category score. We also see that those hypothesized drivers of low PI score, overworked, understaffed, or technology availability in the practices area do not have a meaningful impact on quality category score. Interpreting this further, across a variety of characteristics, small practices consistently produce higher quality scores by a sizable margin.
So to summarize our findings, on average, providers at small practices had lower overall MIPS scores compared with providers at large practices. In contrast, on average, providers at small practices had higher scores for the quality component of the MIPS score compared with providers at large practices. And then aside from those results, it's also important to re-highlight that in our data set, 69% of providers at small practices opted to not report PI data to factor into their MIPS score. Our evidence, we believe, highlights the key limitation of the MIPS methodology, wherein we believe that providers at small practices may be inequitably reimbursed because they lack reasonable incentives to overcome barriers in successfully attaining measures of interoperability, a key target of MIPS, despite the policies that are already in place. What steps should be taken as a result of our findings? One possible approach is to modify the PI category assessment specifically for small practices by implementing metrics that reward them for taking tangible but realistic steps towards promoting interoperability. For example, some metrics could target engaging in the processes necessary for the initial implementation of an EHR system. We also propose that continued targeted support be provided to the significant number of small practices that need assistance in adopting EHR technology, such as the successful Regional Extension Center program. The intended effects of this approach will be broad and involve diverse stakeholders. First, as we have noted, small practices have been observed to have lower MIPS scores. And notwithstanding the importance of interoperability where they score lower, such findings have previously led others to question the fairness and equity of the system. Diminishing payment disparities to providers at small practices will benefit not only the providers themselves, but also the patients they serve by removing one obstacle that could discourage talented providers from working in these settings. Moreover, because interoperability is a component of quality care that can result in improvements in costs, efficiency, and patient outcomes, we hope and expect that this targeted intervention will increase metrics of interoperability in small practices, which will have benefits across the healthcare system. Evaluation of the effectiveness of this approach will be relatively straightforward. First, we can assess for higher PI reporting among providers at small practices. As we mentioned in our data set, the majority of small practices opted out of reporting the PI category. Thus, there's plenty of room for growth in this category, in this outcome. Second, we can assess whether the intervention results in higher overall MIPS scores among providers at small practices. In conclusion, we believe that acting on the findings of our analysis will bring about broad benefits, including an improvement in the quality of care needs. Thank you.
Judges, you have the opportunity to ask questions if you would like.
Go ahead, yeah.
Oh, I was just gonna ask a question, sort of and I'm just thinking about sort of adjacent data. MIPS data for big practices and for big organizations, it's like small ball. MIPS data for small practices is big ball, right? Like it can potentially be sort of a big proportion of what their revenue looks like. That 0.7 still being equivalent to $44 million is a pretty big deal. Did you have a sense for in your sort of data set, kind of that, whether that, just thinking about sort of that proportionality of that sort of overall income for practices, were you thinking about that or using anything from the census to sort of pull in to say, I can take a look at some version of income in a particular area separate from rurality as a way to start to understand that a little bit more? It's a bit about like how practices pay attention to stuff. So, yeah.
Yeah, good question. So two things that we looked at. The first being a percent of the total billing done for the practice that was Medicare billing. So looking at that, similar to what we found here, we didn't find any significant link in quality score as a function of the amount of billing that's Medicare by practice. Also, in the way that the QPP is structured, the annual positive or negative adjustments are done as a percentage of total billing. And so we assumed that large practices, even though they may have other sources of income, because it's done on a percent basis, a positive adjustment could still be quite large. Thank you.
Thank you.
So although this data was not shared, but there is also a summary of the interoperability score for the EHR vendors. So the Epic, which is the most expensive EHR, has the highest score on it. So I think it may be to some degree small practices may be it's hard to afford the expensive EHR. And I don't know if you know this fact, not about this analysis, but if you know about this thing, would you actually change the proposal for the policy? So I wonder if it needs to account for the price of the EHR. Yeah,
That is,
yeah.
that is certainly one of, like,
Yeah.
there's been studies done, what are the barriers to implementing
Mm.
EHR, not upfront capital cost is one of the primary concerns that
Mhm.
people have.
Yeah, also because Epic may not even care for the small practices.
Right.
It has too much implementation costs for them. Yeah, so I think nobody quite cares small practices anymore.
Right, that's why the regional idea is a great idea for that sort of, regional push opportunity, right? And who else can bear the costs? Yeah.
Any other questions?
Maybe walk that proposal forward a little bit. So you've got some ideas about like push on MIPS and federally, what in the heck's happening with the construction of the score. But talk that through, like if there were to be this sort of regional extension hub for, is that support at the practice level? Is it EHR support? Is it a combo platter? What does that look like if you're thinking about that application in person?
Yeah, so something that we discussed as an example would be unique, small practice specific category scores in the PI category. With examples being things that could span multiple years, where because there's this annual calculation of MIPS score, EHR adoption could span multiple years, and so it's hard to incentivize within the calendar year if it's not going to be done by whenever closing time is. It's not worth it for that small practice, where if we implement more checkpoints along the way, maybe some binary, did you contact this QIO in getting your EHR set up this year, could be something that a small practice could achieve within that year, but it's also walking towards full PI category participation.
So yes, and support at like all levels, I think.
I would love for you two to talk to Jennifer Lundblad at Stratus, which is the state's QIO, because I saw everybody see the Minnesota hotspot show
Yeah.
up in the little rundown. I think it'd be great to have that conversation just from an immediate practicable, application.
Yeah.
And
Yeah.
Hi everyone, my name is Najib Fakr Sinamadi. With your PhD student at Because my major is occupational hygiene. On behalf of Team 10, Priority, I'm presenting the results of our proposed study in this competition. In this study, we investigated the role of social vulnerability in cancer screening rate across the US, focusing on 3 types of cancer: breast, cervical, and colorectal. We used Bayesian multi-level analysis while accounting for anti-health indicators and healthcare access. I hope you'll find our study informative. Let's dive into the research question that we are going to answer in our study design. Our first question explores how social vulnerability affects cancer screening rates in different communities. We use the Social Vulnerability Index, SVI, to understand whether communities with high vulnerability tend to have lower screening rates or vice versa. Our second question digs deeper into community health factors. We are looking at how physical health conditions and behavioral health indicators work together with the SBI to create or potentially reduce these disparities in cancer screening rates. Finally, we are examining the crucial role of healthcare access. These include factors like insurance coverage, whether a community is rural or urban, and how well healthcare provider performance. We want to understand how these access factors might strengthen or weaken the relationship between social vulnerability and screening. Here, I'm sharing the current situation of cancer screening in the US. US faces persistent gaps in cancer screening rates for breast, cervical, and colorectal, in spite of clear guidelines by the US Preventive Service Task Force. The socioeconomic environment can be a structural barrier and likely play a significant role, but current studies fail to fully capture how social determinants of health, such as income, education, and healthcare access interact to drive this disparity. Traditional regression analysis often oversimplifies this relationship. Therefore, we employ the Bayesian multi-level approach to better capture these complexities and provide more informed policy recommendations. To address these knowledge gaps, we integrated multiple comprehensive healthcare data sets from 2022 to 2023, allowing us to construct a complete picture of healthcare outcome, access, and quality. Our primary data source is the CDC Places data set, which provides crucial local health information. For the SVI score, we extracted data from the Agency for Toxic Substances and Disease Registry, ATSCR, which provides country-level SVI score based on zip code. I will explain more on this index in the next. Provider data has been instrumental in understanding healthcare accessibility. From this source, we extracted information about the number of healthcare provider per organization and use zip code to determine whether an area is a rural and urban. Finally, to assess healthcare quality, we incorporated a quality payment program metric, the average annual meals. The SVI is a comprehensive measure to identify communities that are particularly at risk during public health emergencies. This index incorporates 16 US Census variables grouped into 4 key themes, which are synthesized into a single measure of overall social vulnerability. SVI scores range from 0 to 1, presenting percentile ranking among all US Census tracts, where 0 indicates the lowest of vulnerability, and while 1 indicates the highest. For our research purposes, we stratified this index score into 3 distinct categories: low, moderate, and high. For a comprehensive country-level analysis, we integrated data from multiple sources. Our study focused on 3 primary cancer screening rates obtained from the CTC Places data set, including breast, cervical, and colorectal. The primary predictor variable was SVI. Our analysis incorporated multiple covariates to account for potential confounding factor, including community health indicators and healthcare access. The selection of these covariates was based on previous research findings and refined through parsimonious model selection. In this parsimonious model selection, we used a correlation matrix analysis with a threshold of 0.8 to address multicollinearity. As you know, detecting and addressing multicollinearity is crucial to ensure the validity and robustness of regression model and reducing the risk of overfitting. In this case, for 2 variables with a correlation coefficient exceeding 0.8, 1 variable was removed to prevent from redundancy. In this case, through this process, we retained 4 key physical health indicators: coronary heart disease, CHD, asthma, diabetes, and obesity. In the parsimonious model selection for behavioral health indicators, we selected 3 key variables: binge drinking, cognitive disability, and depression. For healthcare access, our analysis revealed no significant collinearity where correlation coefficient were less than 0.8. We retained all variables in our final model. We applied Bayesian mixed effect beta regression models to investigate the relation between social vulnerability and cancer screening rates. Our methodological framework incorporated a state level random effect to address geographic clustering. Beta distribution was selected to appropriately model screening rates bound between 0 and 1. To systematically evaluate these relationships, we developed 4 models, 1 unadjusted and 3 adjusted models. Based on sensitivity analysis and BIC, the 4th model was identified as the most appropriate. Therefore, we reported the result of this model in our next slide. Model estimation used INLA for computation and efficiency, and all the statistical analysis was conducted using RStudio version 4.2. Here we have the data for the distribution of cancer screening rate, community health indicator, and behavioral health indicator, and health access across the social vulnerability index. Higher SVI are associated with lower cancer screening rates, particularly for cervical and colorectal cancer. Physical and behavioral health conditions, including diabetes, obesity, and depression, are getting worse as the SVI increases. Healthcare access disparities are evident with higher uninsured rates and fewer provider per organization in high SVI area, which is highlighted the structural barriers to healthcare access. This figure illustrates the distribution of breast cancer screening rates across the US with a country level heat map on the left and the regional level on the right. Counties shaded in blue represent screening rates above the national target, while those in solid and dark red indicate low and very low screening rate, respectively. The highest screening rates are concentrated in the northeast and much of the southeast. In contrast, the lowest screening rates are observed in the western and southwestern states. The geographic disparity is likely influenced by factors such as differences in healthcare infrastructure, urban, rural status, insurance coverage, and state level healthcare policy. As far as blood, it shows the odds ratio and 95% credible interval for predictor of breast cancer screening rate in both unadjusted and fully adjusted model using low SVI as a reference. In the unadjusted model, both moderate and high SVI were significantly associated with lower odds of screening. However, in the fully adjusted model, the effect of moderate and high SVI weakened, but still remain negative. Thus, other factors may mediate this relationship. For example, coronary heart disease had this the strongest negative impact, potentially due to patient prioritizing cardiac care over cancer screening. Conversely, diabetes was associated with higher screening odds, likely due to more frequent medical visits. In addition, cognitive disability and lack of health insurance led to reduced screening rates that highlight barriers to healthcare access. This figure shows cervical cancer screening rates across the US with a country level and regional level. Overall, cervical cancer screening has the highest uptake compared to breast and colorectal, but geographic disparities are similar. Higher screening rates are focused in Northeast and Upper Midwest. In contrast, lower screening rates can be observed in the Western and Southwestern regions. Factors contributing to these disparities may include access to healthcare facilities, urban rural-urban status and differences in insurance coverage. Here are the results for cervical cancer screening rates with the low SBI as a reference. In the unadjusted model, moderate and high SBI showed significant negative effects on screening rates compared to low SBI. However, in the fully adjusted model, these effects are significantly attenuated, suggesting that other variables may mediate this association. Cognitive disability has the strongest negative effect, indicating lower screening likelihood for individuals with cognitive impairment. In contrast, asthma, diabetes, and obesity show positive association with the screening. This figure presents data on colorectal cancer screening rates across the US on the county and regional levels. The geographic distribution highlights that the lowest screening rates are concentrated in Texas, the southwest parts of Montana, and the mountain west. These areas are often rural, medically underserved, with significant Native American populations that contribute to disparities in access to healthcare and screening services. These observed disparities may be driven by factors such as limited access to healthcare facilities, cultural and language barriers, fear of invasive procedures, and socioeconomic status. The results of Bayesian regression models for colorectal cancer rates are presented here. In the unadjusted model, moderate and high SBI were significantly associated with lower screening rate. Surprisingly, after adjusting for other variables, these effects almost completely disappear. This suggests that other factors may drive screening disparities. For example, cognitive disability had the strongest negative impact, likely due to challenging in understanding follow-up care and procedure complexity. Lack of health insurance was a major barrier due to high cost of colonoscopies. Coronary heart disease also negatively impacts screening rates, possibly due to procedural complication, medication interactions, and competing health priorities. We have key findings and clinical implications for breast, cervical, and colorectal cancer screening in this table. For breast cancer, integrating cardiac and diabetes care with screening visits are recommended, with increasing insurance coverage to address access barriers. Cervical cancer results suggest focusing on SBI and integrating screening with chronic care for conditions like asthma and diabetes, with creating accessible support program for cognitive disabilities. Colorectal cancer screening emphasizes linking between mental health services to address binge drinking and developing simplified screening programs for individuals with cognitive disability. The results also underscore the importance of addressing specific health and social barriers to improve screening rates. Overall, targeted intervention that consider both medical and social factors are crucial for enhancing cancer screening outcomes. We propose solutions to improve cancer screening. In integrated care navigation system, a centralized approach that reduces healthcare fragmentation by standardizing protocols, minimizing redundancy, and streamlining patient tracking for more efficient and comprehensive screening coverage. A smart risk stratification emphasizes a personalized screening model that leverages advanced data analysis to incorporate genetic, behavioral, and social risk factors. This approach enables targeted intervention and address psychological barriers to improve patient engagement. Technology-enabled support tackles access barriers by offering digital preparation assistance, remote monitoring, and automated coordination, which simplify logistics and enhance accessibility for underserved populations. Together, these components create a holistic, efficient, and patient-centered system that improves screening participation and outcomes. We developed a comprehensive implementation plan with action steps and evaluation strategies at both the practice and policy levels. At the practice level, risk assessment and intervention planning are used as data-driven models to identify high-risk population, predict barriers, and refine their strategy. In addition, we can also ensure efficient allocation of staff and resources based on community-level data in resources optimization. At the policy level, data integration and quality assessment incorporate SVI metric into evaluation, while interdisciplinary coordination promotes collaboration across clinical, behavioral, and operational. The evaluation and impact strategy monitor improvement in screening rates, the efficiency, effectiveness of patient support, and resource efficiency, ensuring adaptability through ongoing stakeholder feedback. This holistic approach ultimately enhances healthcare outcomes. We applied an innovative solution approach that integrated Bayesian analysis with ATSCR SVI to enhance risk assessment and targeted healthcare intervention. The Bayesian approach enabled precise risk modeling, predictive insights, and resolve uncertainty quantification. It also supports a small area estimation, capturing geographic interdependencies and nested data structures for rural and underserved communities. The integrated SVI enables multi-dimensional community vulnerability analysis, ensuring that targeted intervention effectively addresses disparity. Thank you for your attention. I hope you all enjoyed.
When you look at the cervical cancer screening, if you can go back to the map of the cervical cancer. Yeah, I wonder if you overlay the political students.
Actually, no, we didn't look at this one. Yeah, we just use the SVI score and other variable that we mentioned in our model, but it's a good step for the next level to look at the particle students. But as you see, maybe we can say, I think the northeast part or upper Midwest, we have higher cervical cancer screening rate that might be somehow related to religious or cultural barriers. So yeah, we should in the next step, apply this variable as well, but in the system, we did not.
I just remind me of yeah.
So the one question I had was actually around another map. So the colorectal screening rates. So what stuck out to me there were a couple of the state boundaries that really stick out, you know, like between California and Oregon, and then also Wisconsin really sticking out. Was there some clear reason you could point to for the data?
Actually, for California, I see maybe again cultural belief, specifically when we look at the invasive procedure of colonoscopy or required specialty or high cost of that, and for the Wyoming part as well. And the other thing maybe related to this is on the insurance coverage. We just have insured people and uninsured, and we don't know about which patient have commercial insurance or the Medicare insurance or Medicaid. So I think for the specifically California part, this insurance coverage may play a role.
Yeah, I was going to ask a question about Medicaid, Medicare coverage information. The cognitive disability piece really stood out to me. You know, for that to sort of flag, it's almost always got a caregiver in that mix. It's almost always dual eligible humans. And so there's like just some complexity in sort of that insurance coverage piece that is less about interventions that might be about that cognitive disability and more about the systems and the structures that are kind of wrapped around those humans and those caregivers. I did have a question about given the presentation we just heard about kind of the under throttling of electronic health records in rural areas, which we kind of know to be true. We know all the issues in sort of the, sort of rural spaces in this country. I'll set aside culture, beliefs, mix, all that other kind of stuff. But just thinking about those practices, you've got proposals that are really built around, right, smart decision-making that are enabled by technology, blah, 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 all that kind of stuff, the flags that exist inside the record, all that kind of stuff. So take the record out of that, knowing that we've got tricks in those spaces or may not be as mature in those spaces as it is elsewhere. How might you think about those interventions deployed in a different fashion than through those technology platforms? They were great suggestions, but if you don't have the EHR to manage it, as you look at kind of your proposals, how might you pivot those to think about, especially those places in the country that stand out here as rural spaces? What would that look like?
Proposal most rely on the targeted intervention. So when we propose, okay, we need to technology and support, we should focus, okay, this hospital or this clinic doesn't have very strong technology support or something like, for example, Epic for EHR, and so we need to define a targeted intervention, and it should be different between rural and urban status, or it should be customized based on the technology, capability of the community, tailored based on their culture, based on their language, or based on the caregiver they have, and insurance coverage, and all of them. So our proposal must rely on the targeted intervention rather than a uniform approach for all of this content.
Great, thank you.
I have a question. Can you go to the slide where you had the sort of key indicators of the screening? Why do you think, or did the data show that why there were such differences? So coronary heart disease only is an indicator of breast cancer, and asthma is only for cervical cancer. Is there?
Yeah. For coronary heart disease, there is a fear of chest radiation interaction for breast cancer. So in other cancer, we see the patient with almost all chronic conditions such as asthma, such as diabetes or coronary heart disease, because of increasing healthcare provider encounter, we had a higher screening rate. But specifically for the breast cancer, because of chest radiation due to mammogram, patients have a fear of higher cost, higher adverse event rather than cancer screening. So this is a result because of this. We have discrepancy here.
Thank you so much. So we have a little break schedule, like 15-minute break. If we could maybe come in 5:05. And we'll go to team one.
Very impressive, yeah.
All right, so yeah, so along with our preliminary analysis of RA prevalence across the US, where we mapped out, or well, we used the competition data set to perform a preliminary analysis. And so these collective findings, they serve as our motivation for our research questions of interest. From there, we'll transition into walking you through our exploratory analysis results, along with the solutions to address the disparities that we identified through our data analysis. Alrighty, so what is RA? So RA is a chronic autoimmune disease, meaning that the body's own defense system accidentally attacks the lining around the joints. And this can lead to painful inflammation that's caused by the swelling, stiffness, and deformity that can emerge from the inflammation. And so what's less known is that RA is systemic, meaning that it can impact other parts of the body outside of the joints. And so, for example, it can impact the lungs, heart, eyes, all of which can lead to other serious health complications. And unfortunately, the cause of RA is not known, and therefore there's no cures. And so you can only manage the symptoms. That's why early diagnosis, along with proper treatment and lifestyle changes, are critical for relieving symptoms and preventing adverse health outcomes, including irreversible joint damage, disability, or premature death. And so approximately 1% of the US population is affected by RA. And although not much is known about RA, what is known is that it doesn't impact everyone equally. Its prevalence is based on different factors. For example, older adults, they're more prone to developing RA. And this is problematic given the growing aging population in the US. And so I've listed a few other factors that can increase an individual's risk for developing RA. And beyond these risk factors, unmanaged RA can lead to severe consequences, primarily limited physical mobility, which, as one can imagine, reduces quality of life as it disrupts daily activities, relationships, career opportunities, and it can also lead to mortality. And so aside from the emotional burden for the individual and their support system, RA also weighs heavily on the healthcare system. The total annual healthcare costs associated with RA has been estimated to be a staggering $19.3 billion. And so collectively, these reasons highlight why RA is an emerging public health concern. And so previous studies looking at factors that contribute to the disparities in RA care have found notable geographic trends. So to summarize some of these results, what they found was there's higher RA prevalence among southern states, particularly with folks who are enrolled in Medicare and Medicaid. In addition, southern states were found to have limited access to specialized care. And the few clinics that do exist, they serve a high percentage of RA patients. And these patients were found to travel long distances in order to receive this specialized care. And this is true for folks who are from the south and the west parts of the US. Other findings include patients who come from urban areas. They were shown to have higher access to more specialized services and diagnostic testing, whereas rural patients, they relied heavily on the primary care system. And so with these factors, or well, overall, these findings, we were motivated to further explore how geographic disparities influence RA care. And so for our preliminary analysis, we used the competition data set to map out the total count of RA cases by state. And so we can see that deeper shades of red are associated with higher case counts. So taking a closer look, we can see that states with higher populations such as California, Texas, and New York, they all reported higher numbers of RA cases. And so the next question we asked was, well, do these states also serve more severe cases of RA? And when we performed this analysis, we found that we lose North Carolina, but we gain Michigan. However, the rest of the states remain the same. And so in summary, states with larger populations have a higher prevalence of severe RA patients. And so with these findings, we were motivated to address the following questions. How do geographic areas influence the prevalence, healthcare costs, and quality of care for patients with RA? And what public health strategies and policy interventions can we use to promote equitable access to RA care across the different geographic areas? And so with these questions guiding our analysis, I'll pass it over to Sarah, who will walk us through our data analysis approach.
Thank you, Ingrid. So for our data analysis approach, we used a variety of features from the competition dataset, which includes provider data, quality payment program, Medicare utilization, and CTC places data. Within this information, we also have access to providers' county, sex, specialty, MIPS score, and payment, which means merit-based incentive payment system, and then total beneficiaries and their physical and behavioral health-related data for the year 2022 and 2023. In addition to this, we have also used the Healthcare Provider Taxonomy Code from NUCC, which stands for National Uniform Claim Committee. This helped us group all the health providers' specialties into few major categories. In addition, we have used RUCA codes to classify zip codes as rural or urban. For the pre-processing step, the goal was to find the medical specialties to focus on our data analysis. We did this by classifying the provider's specialty into 9 major categories. For example, if the provider is a part of internal medicine or surgery. And as mentioned, this was done using NUCC provider taxonomy codes. Then we did the disparity analysis based on quality index, which includes the MIPS score, Medicare payment, area, and health complexity of the beneficiaries. Briefly, we found that less severe cases of RA among rural beneficiaries have higher average service costs than the urban beneficiaries. So this suggests that geographic disparities impact cost and availability of services. Using these results, we performed a root cause analysis to find the possible causes and propose solution strategies like knowledge-based solutions and machine learning-based solutions that can contribute to policy interventions. From the given provider data analysis, we have found that the internal medicine providers handle the largest amount of beneficiaries with high health risks in USA during the year of 2022 and 2023. Here, green bars present total number of beneficiaries, where blue bars indicate the average beneficiary risk score across 9 major providers group. Now, within the internal medicine, rheumatology has one of the highest Medicare payment per beneficiary. In this figure, the orange bar shows the payment amount for rheumatology, which is around $1,600 per beneficiary, and is the 3rd highest among the other subspecialties in internal medicine provider group. This suggests that rheumatology services are high in demand. Looking at the data from rheumatology providers, we analyzed the health complexity analysis between urban and rural beneficiaries. This shows that health risk scores are higher for urban beneficiaries in orange compared to rural beneficiaries in blue. Then we divided the beneficiaries' health complexity into 4 major categories, as shown here on the x-axis of this figure. Health complexity refers to the overall burden of a patient's medical condition, including chronic diseases, comorbidities, and other factors that impact healthcare utilization and cost. Based on this health complexity analysis, we have found that the average service cost for rural beneficiaries in lower health risk groups is higher than in urban areas. And there is a significant gap between the average payment per service for rural and urban beneficiaries in the 0.5 to 1 risk score range, as shown here. We have also done the cost analysis by MIPS score between rural and urban beneficiaries. The MIPS score represents the merit-based incentive payment system. Here we divided the MIPS score into 3 major categories based on the literature mentioned in this slide. Scores below 30 indicate below par performance. Scores between 30 to 75 represent good performance. Scores above 75 reflect exceptional service. From the box plot, we observed that the median cost per service for rural beneficiaries in different MIPS category is higher than urban areas. The white line between each box plot represents the median value. From this quality-wise analysis, we can conclude that the average cost of service in RA is higher in rural areas, which is one of the key focuses of our study.
Thanks, Howard. As a summary of our findings, we have found that there are 9 key states where RA prevalence is higher than other states in US. Next, we found that rural beneficiaries face higher costs per service compared to urban counterparts. And we have also found that even for lower complexity cases, costs remain significantly higher for rural beneficiaries compared to their urban counterparts. So next, we have conducted a root cause analysis to understand why RA prevalence is higher in those 9 key states. So first, demographics play a significant role. So according to Administration for Community Living, or ACL, it is found that in 2022, more than half of the population above 65 years old lived in 9 states. And these are the 9 states we found from our data analysis to have higher RA prevalence. So this translates to larger Medicare population and elderly population having higher RA. Next, looking at lifestyle factors like obesity and smoking, both known risk factors to RA. And in this states, the rates for obesity and smoking are higher than US average. Next, environmental triggers such as exposure to high particulated matter due to urbanization or pollution. So these 9 states are highly populated and industrialized. So that is also one of the factors. Lastly, looking at socioeconomic factors. So these are highly populated states, right? And also the proportion of low-income population is also higher here. So this means limited access to healthcare, and so. Additionally, these states have industrial jobs and exposing workers to chemicals, which are known attributes to RA. So by identifying these key factors, now we are going to focus on targeted interventions. So to address this, the high prevalence of RA in these 9 states, we have identified some interdisciplinary key strategies. So starting with demographics, we need targeted policies for elderly care, right? They have the highest population having RA. So creating RA support network has shown statistically to help elderly population to access care. Next, lifestyle modifications can play a significant role. As simple as it may sound, but community outreach programs and public awareness campaigns can educate people on the risks of RA and also promote healthy eating, physical activities, and this can prevent early onsets of RA. Promoting green technologies can reduce the harmful effects by the environmental triggers that stakeholders can consider. Moving to socioeconomic factors, so we must ensure access to affordable medication programs, which we all want, and also a stricter occupational safety regulations at workplaces, and also implement regular health screenings for the workers who are at high risks of RA. But at the core of all these strategies are policy interventions. So that can involve allocating research grants or like resources for research for elderly population having RA, because they are the most affected people having RA. So in addition to this geographic analysis of these 9 key states, one more result of our analysis was that rural beneficiaries incur higher Medicare payments compared to their urban counterparts. So this trend can be attributed by several key factors. For example, rural areas often have fewer hospitals, fewer specialized providers, making the timely care more difficult. So from the table seen here, so we have found that out of the 156 providers who served rural beneficiaries, majority of them, 136 of them were actually urban providers, and their average service cost was $56.8 US, which is significantly higher than the 20 rural providers staying in rural areas, serving rural beneficiaries, and their average service cost was $40. So this means that rural residents were traveling to urban areas for specialized care, which often comes at a higher cost due to the rate differences in rural and urban areas, and also expenses associated with travel and extended treatments due to not having timely care. So to mitigate these geographic limitations, telemedicine can be an essential tool. So American College of Rheumatology encourages patients, especially elderly patients and also patients in rural settings, to use telemedicine services because that can reduce the stress of travel. Also, accountable care organizations or ACOs can improve care coordination between healthcare providers, resulting in reduced healthcare costs. Other strategies could be non-emergency medical transportation, which can assist rural patients to commute to and from their appointments. So studies have shown that this can reduce hospital readmissions by at least 20%. So lastly, grant programs for rural hospitals. For example, Rural Hospital Accessibility Program or FLEX has helped over 1,300 rural hospitals till now. So apart from this knowledge-based interdisciplinary solutions, we are also proposing a machine learning-based model-based solution to predict the health risks of the beneficiaries. So this could be helpful for rural hospitals, but to be honest, this could be helpful for any settings. The input for our model here involves the data from the 9 key states where we found that RA prevalence is higher. So this also the data includes beneficiaries' behavioral and physical information, providers' MIPS score, payment information, and all the other features that we had from the data set. So our model consists of 3 comprehensive machine learning algorithms, and we use majority voting to predict which provider groups are more likely to serve higher risk beneficiaries, so that we can identify those provider groups and have targeted interventions or have appropriate measures taken especially for them. So the health risk class were already discussed. There are 4 health risk groups and with increasing scores, meaning higher health risks. So our model would help identify the providers who would be serving the higher risk population. And our model's predictive capability is demonstrated by a high area under the curve value of 0.95 and also a high accuracy of 79%. And the true positive rate for critical classes, like for determining which providers are going to be serving with beneficiaries with risk score greater than 2 is like 89%. With this model can predict those beneficiaries by accuracy of 89%. So from our model, we can also gain insights on how other medical or non-medical factors can impact these predictions. Like, for example, we have found that the influence of dementia prevalence among the beneficiaries has the highest impact on this prediction. So this was one of the feature importances. So this means that cognitive health indicators should be taken into consideration when we are assessing health risk. But one of the key limitations of this model was that we had the data for 1 year for 2022 and 2023. But if this model is like fed with more data each year, it could dynamically refine feature, like we could dynamically refine feature importance and predictive accuracy. And this tool could be implemented by stakeholders and can proactively identify providers with high complexity patients and allocate resources effectively. That's it from team 1. Thank you for hosting this competition, and thank you Mimilab for providing the data, and thanks judges and everyone.
You had a comment that the rural beneficiaries travel to the urban. Is it kind of something you guess, or was it a kind of?
No, we found that out, that the 156 providers and rheumatology providers, they served only rural beneficiaries, but the location, like 136 of these providers were actually located in urban areas. So, but they were serving rural beneficiaries.
And that's also something that we found in the literature as well, where rural patients would travel to urban areas for specialized care.
Which matched from we found from the data.
It's a little bit the side topic, but the RA is particularly interesting in the business because there is this drug called Humira.
Yeah.
which is very expensive. And yeah, I was kind of guessing there is another program called the 340B that makes the rural, providers to cheaply purchase those drugs. So I was wondering whether actually it was just oversubscribed, subscribing in the rural area, but I wasn't sure that whether actually they are traveling to the urban side. So, yeah.
Your prevalence for RA cases by state, were those reported per capita or just prevalence in general?
Just
Numbers.
the numbers.
Numbers, right.
The beneficiaries are from that particular state.
Can you talk a little bit more about, I feel like rurality is our theme of the evening.
Yeah.
So, so you've got some solutions that are about, sort of telemedicine, additional supports in sort of rural spaces and places, right? So you're thinking about that as kind of what that looks like. Again, given less saturation of electronic health records in rural spaces, given older adults, technology comfort, broadband issues, you name it, in sort of rural spaces and places, given transportation issues. How would you think about, there's sort of that second level set of problems that you've got to navigate now based upon some of the things that you've suggested? Walk us through, I'm going to take transportation forward, or I'm going to take EHR access forward, or I'm going to take technology forward. Walk through any of them, pick one. I'm just curious about kind of the next level of what that implementation or that response looks like, especially in communities that are going to have limitations on what this looks like.
You want to take that one?
So, I mean, there's a few ways to look at it, but what we're proposing in our solution is to use implementing that machine learning model using the data that's already available. And from there, our idea is to allocate resources to the areas that are serving most severe RA patients. And so that's one way of looking at it. But through the US Department of Health and Human Resources, they have a plan called Healthy Plan 2030. And through that plan, one of their goals is to reduce chronic pain and misuse of prescription pain relievers. And under that, one of the objectives that they have is to reduce the proportion of adults with arthritis who have moderate or severe joint pain. And part of that, they're implementing these programs that we already suggested. So we're not really inventing something new, we're just using what's already out there.
Also, if I may add, so this rural hospitality, the rural hospital flexibility program, Flex, it was actually started from 1997. So this is not something like new. So we feel that, but yeah, the scarcity of resources in rural settings. So that is why we are proposing this solution, this machine learning based solution, because this model could be trained with data from other settings, but can be employed, this can be employed in rural settings where we might not have all those data. So yeah, if that answers your question.
Yeah, I just think that right, we know rural communities are at risk. We know rural hospitals, despite all of these supports, are closing. So sort of the, continue to think about all these innovative solutions, especially in spaces where throwing money at it isn't going to fix it, right? Because there isn't anything to throw money at. Yeah, just that it really forces you to take it even one step further. Yeah, but thank you.
Well, thank you so much. 14.
After BC cross coordinate economic health.
We need a few seconds to adjust. Oh. So good afternoon, everyone. Sorry for the waiting. So we are team 14. My name is Crystal. I'm the JD MBA dual degree student from Carson and Law School.
My name is Subin. I'm a PhD student in epidemiology program.
My name is Yuka, and I'm a first-year master's student studying mathematics.
My name is Wanli, and I'm a second-year MPH student studying epidemiology.
So today we will be discussing an important issue in healthcare equity. So how the merit-based incentive payment system MIPS fails to incorporate social determinants of health and why that matters. So first, we will start with our conclusions. So we identified two major conclusions in our research. First, through our literature review, prior studies show that physicians serving socially disadvantaged patients tend to receive lower MIPS scores. Just a quick reminder, although you've heard a lot about MIPS today. So it is a scoring system that was designed to reward or penalize physicians based on the scores they got. So turning back to our second conclusion is that our data analysis confirms that these physicians that serving a socially disadvantaged patients frequently tend to have negative Medicare payment adjustments despite providing comparable quality care. So we're gonna take a closer look at these two conclusions and see the relationship between MIPS scores and Medicare payments. So this chart illustrates how MIPS scores influence Medicare reimbursement. So first, we can see there is an initial Medicare allowed amount, and then there's an adjustment made based on the physician's MIPS score, and then finally, after the adjustment, this is the final payment amount of the Medicare reimbursements received by the physicians. So from this chart, we see that MIPS scores directly impact Medicare reimbursements. And since, as we previously mentioned, physicians serving high-risk communities consistently receive lower MIPS scores, they experience negative payment adjustments, reducing their reimbursement amounts. So our data analysis also confirms this pattern. And we believe that incorporating social determinants of health down here into the MIPS scoring is a crucial step to address the current issue. And to further understand why this is the right solution, let's see how MIPS is calculated currently. And I'm gonna make this short. So 30% of the score assigned to the quality of care, 30% assigned to cost efficiency, 25% assigned to interoperability, which is to evaluate how well physicians use electronic health records and data sharing, and the last 15% assigned to the physicians' engagement in efforts to improve healthcare. So focusing on these four metrics, it is especially the last two, it becomes clear and almost intuitive that providers in high-income areas have an easier path to meeting these performance standards. And in contrast, those serving disadvantaged populations, they may face like limited funding, outdated system, and also like higher patient complexity. And all these factors will make it harder for them to score high in the current system. And this oversight results in a system that unintentionally penalizes providers in underserved areas. So here, based on our previous conclusion, we identify three key problems under the current framework and propose three solutions. So the problem is that
As we mentioned previously, the negative Medicare adjustments received by physicians serving disadvantaged patients lead to lower reimbursements, and this widen the health disparities currently in the state. And our proposed solution is to first adjust MIP scoring to incorporate social determinants. Second, to provide additional support for those physicians. And third is to improve data collection. So next, we will dive deeper into our data analysis and see how they support our conclusions and findings.
So our aim of this data analysis was to look at the patient's payment system, especially for those who are caring for patient under Medicare, and adverse social determinants of health. So to do this data analysis, we utilized two different data sets. So first one is from MimiLab data, which was required for this data competition. And then the second data set, we got it from external data source, which is from Center for Health Disparities Research from the University of Wisconsin. So this was a publicly available data set, and they offered ADI score, which is the Area Deprivation Index score, that is measuring the social determinants of health data. They are utilizing the socioeconomic factors related to income, education, employment, and housing quality. So we specifically use the national percentile ranking for the ADI, which is from 1 to 100, where 1 is least disadvantaged neighborhood and the 100 being the most disadvantaged area. For the purpose of this presentation, I will refer ADI national percentile ranking as ADI score. So here is a map. We are showing the distribution of ADI score, which is from 2022 data by zip code level. Here, the red color coded area is showing the high ADI score versus green color coded area is showing the low ADI score. And so we will zoom in on some of the states later on in this presentation. Before going into that, we have another map. This is showing the distribution of MIP score by zip code. And this is also 2022 data. So we can link it together. And this is showing specifically for MIP score less than 75 points. We picked this point because this is the minimum score that is required for providers to achieve to avoid negative payment adjustment for Medicare procedures. So now we are going to look at some of the states side by side, looking at ADI score and MIP score. So before going into that, I just want to remind you one more time that the green color-coded area is low ADI score, and the red color-coded area is higher ADI score. Higher the ADI score is more disadvantaged area. So this is Minnesota where we are right now, and we can right away see the low ADI score is clustered around, it's clustered around big cities, Minneapolis and St. Paul. And more like a rural area, we can see the higher ADI score. However, I just want to point out that even though there is a lower ADI score in big cities, we still see some disparities. Looking at this side of the map, this is a MIP score less than 75 point distribution, which is shown in the areas that has higher ADI score. There's a second example. This is California, and we see the similar pattern. So along the coastline, and big cities like LA and San Francisco, we can see the ADI score that is lower versus rural area, semi-rural area, we see the higher ADI score. And again, the MIP score less than 75 points is distributed around where ADI score is higher. Another example is Texas. So again, this is very interesting. We can see that low ADI is clustered around big cities like San Antonio, Houston, Austin, and Dallas, thank you. And then the rural areas, we have higher ADI score. And then again, we see MIPS score less than 75 points. They are distributed around where ADI score is higher. If I haven't convinced you guys yet, we have many more states that we have it as an example. And really, like, we see all these similar patterns all over the United States. So now that we looked at ADI score and MIPS score on the map as a visualization, you can go over statistical regression.
Okay, so now that our maps tell us that higher ADI generally correlates with lower MIPS scores, so to validate this, we did a linear regression on MIPS score and ADI, but we didn't get any statistically significant result. Given that rural areas tend to have higher ADIs while urban areas tend to have lower ADIs, from the maps we see, we shifted to examining MIPS score based on urban versus rural patients. Okay, so for our analysis, we define urban as very developed areas and rural as underdeveloped areas. So we created a new variable to transform the continuous MIPS score in the dataset into a categorical variable. And while the 2022 MIPS score framework had 5 payment adjustment categories, we reduced it to 3 for statistical significance. And you can see it from the x-axis in our bar chart. So now since MIPS scores are ordinal, we applied a proportional odds logistic regression. And then we controlled for the confounding variables by first fitting an initial model with all the predictors, and then we refined it using stepwise selection, feature importance scoring, removed variables with VIF greater than 10, and then lastly, we computed the predicted probabilities using the inverse logic function and averaged them based on MIPS score range and rural status designations, which is the bar chart we have over here. And just to remind you, light blue is rural and dark blue means urban patients. And we can first take a look at the negative adjustment here. So you can see that providers serving rural patients are 2.4 percentage points more likely to receive penalties compared to their urban counterparts. And if we take a look at the high adjustment, providers serving rural designated patients are 3.35 percentage points less likely to receive benefits than their urban counterparts. So from the previous information by Crystal, we learned that MIPS is a reward penalty system based on quality and efficiency. So it means that payment adjustments can be influenced by non-social economic factors. So to isolate the impact of socioeconomic factors, we examine the relationship between ADI and total Medicare allowable amount. So we focus on providers with MIPS score less than 75 to better assess how economic deprivation contribute to reimbursement disparities. And we use a multiple linear regression model with the same feature selection process. And we can take a look at the table over here. So then you can see that 1 unit increase in ADI implies $1,400 decrease in Medicare allowable amount, holding all the other factors constant. And this graph is just a simple linear regression, which shows the same trend. So now we learned that providers in higher ADI areas receive lower Medicare allowed amount. We want to investigate how Medicare allowed amount relate to MIPS scores. So if we look at we use another multiple linear regression model here, and you can see that each additional increase in MIPS score is associated with a $1,500 increase in the Medicare allowed amount for low scoring providers, even after accounting for rural patient proportion and of course all the other factors. And this is a very, very powerful result because it tells us that association is not just due to rural urban designations, rural urban disparities, but likely due to the MIPS system itself. So from all our analyses, the story becomes clear. So we have rural area have higher ADI, and a higher ADI implies higher penalty and lower benefits. Higher ADI also implies lower Medicare allowed amount. And lastly, lower MIP score implies lower Medicare allowed amount. So hence, the MIP system systematically disadvantages providers in underdeserved areas. So we want to create a policy to include social determinants of health, therefore increasing MIP scores and final payments for those providers. So despite our analyses have limitations, 3 of our strengths are we merge an additional data set to incorporate social determinants of health. We use 3 data tools, which includes Tableau, R, and Excel. And all 3 of our models control for confounding variables. And next, Wang Ling will discuss the potential policy recommendations.
So now that we have the compelling statistical evidence showing the disparities within our current MIPS system, it is time to introduce MIPS 2.0. We continue to prioritize the cost and quality categories at 30% each as they convey the MIPS core mission. However, we will adjust 10% out of the interoperability and 5% from the improvement category to reallocate these 15% to our new social determinants of health category, for the reason that these 2 measures tend to overlook the unique challenges that rural providers face when serving vulnerable populations. So as part of our reallocation, our 5th category will assess these 5 items via a Centers for Medicare and Medicaid Services provide the assessment, which will show up for CMS. So by incorporating our 5th social determinant factors, we aim for a more comprehensive and equitable assessment of the provider's performance. Next is our implementation plan. We have 3 key components. First is to integrate social determinants into the current MIPS system. For that, we will expand data collections on the social factors, and we will join forces with CMS to adjust the MIPS scoring. And next, we will align financial incentives to minimize the disparities in the MIPS system. And second, we will develop provider training to emphasize the social determinant factors in care delivery alongside a standardized data collection protocol. And finally, we will engage government agencies and hospital administrations to increase the participation rates and provide supports, advocating for policy changes that incentivize the social determinant data use in MIPS 2.0. So our innovative MIPS 2.0 creates an even-handed and evidence-based reimbursement system. It's feasible because it builds upon our current MIPS system, and it also utilizes a CMS validated survey tool. By engaging a number of stakeholders, we hope to develop a comprehensive healthcare scoring system that will work in the real world. So how are we going to make it happen? Our action plan features a tentative timeline and evaluation process. We will assess improvements and track the utilization of the data among providers. So beginning in 2026, we will work with the CMS to launch our pilot MIPS 2.0 data collection across several states. By 2027, we will distribute online surveys to gather providers' feedback on the MIPS system. In 2028, we will collect new MIPS 2.0 scores that evaluate how system impacts the rural providers who serve underserved populations. This initiative will reach an end in 2029 with system refinements based on our previous feedback and analysis, followed by a wish for nationwide implementation. So why makes it different? It enhances health equity by addressing disparities in underserved communities. It also implements holistic assessment methods, incorporates social risk factors, and provides comprehensive benefits across healthcare. So in summary, our analysis merged 2 data sets to explore the flaws of the current MIPS system. With a new metrics added to the MIPS 2.0, we directly address payment inequality facing providers who serve undeserved populations. This newer system also offers very straightforward implementation while transforming healthcare reimbursement into a more equitable framework. So through MIPS 2.0, we are taking a decisive step towards healthcare's justice. So that concludes our whole presentation. Thank you so much for listening.
They need to run the law.
So the question for you about, so you made a decision to think about, this is gonna take me a little while to get to the question. And I sort of have two parts. So you made a decision that providers ought to be collecting additional social drivers or social determinants of health data versus using existing data that may, be out there at the tract or the block group or the blah, 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 pick a geographic unit level. Talk a little bit more about why you chose individual level provider data collection versus the use of some of this like broad sort of extant data. I appreciate the ecological fallacy that may exist at that sort of group level, but walk us back from a macro vantage point. Why that versus using sort of the existing sets of data that could be a decent, air quote, sort of proxy for kind of that individual level data collection.
In the data set we were given, it originally only includes individual providers. That's why we perform our data analysis based on individual provider only. And that's also in our limitations. If we were given more time, we will expand our analysis to include the providers who are with the group or the virtual group and with organizations.
I like it. Yeah, sort of could you see if the data that you have around social drivers would hold true underneath your analysis at kind of that individual level provider vantage point to justify whether or not you would ask folks to collect more information? I say that because docs typically, NPs typically, PAs don't want to be collecting information that they can't act on. And it's extraordinarily difficult for those providers to change social drivers. So my second question, just about MIPS in general, which, I think clearly it's got issues. We've sort of seen that, is that MIPS payments, quality payments, value-based payments in healthcare right now, and the way we pay providers actually goes to systems. Even if it's a rural clinic, it goes to the clinic. It doesn't go to the individual provider, right? So it's not really incentivizing at an individual level behavior change in individuals. It's part of the fault of the big system, right? It goes to the system uses those monies differently. So collect information, make adjustments at that individual level. Solving social drivers issues, especially in rural or hyper-vulnerable communities, is incredibly costly. So I'd love if you talked a little bit about kind of, how might you think about that percentage and the overall MIPS payment? And is there an adjacency there that would yield systems, clinics, communities to be able to do something different, right? Because it's hard I might get a little bit of extra money as a provider, but I can't change the fact that Haley does not have transportation on a regular basis to the clinic. That's a bigger systems issue, but the incentive is coming at the level of provider or sort of system. So talk about kind of breaking that apart inside the broader MIPS structure. How might you think about that? That was like 17 paragraphs. I'm sorry. It's just like it's such an interesting incentive alignment question. Yeah. And if you're like, that'll be next year. Just thinking about it's one thing to tune the system for the individual. It's another thing to figure out where the cost is born for the solution in response to the thing that you're tuning the system around, right? Sort of that, physicians may have some power over some of that cost quality in the moment, but they lose that power when we throw social drivers into that equation. I don't think there's disagreement that you have to adjust for that. It's just that, MIPS was put in place to yield solutions in the environments it could be deployed, and adjusting for social drivers doesn't allow for that because that's not where the thing's going to get better from a social determinants of health vantage point.
So one of our proposal was to collect the data on individual level of each of the patients, and then we are planning on working with the state level health department and other stakeholders to provide resources on for those patients who needs extra help and provide those resources. So that's a little bit included in our future plan.
Great, thank you.
I mean, I just have one comment, not a question, but it'll be interesting to calculate the amount of exposure that is driven by the accumulation of this the negative adjustment. Yeah, I don't know how that impacted the over time, but others. Having that number can be probably not significant. If you can scientifically calculate that this is why things got negative impact. Yeah. Maybe people from the rural may sue the government.
Well, thank you so much.